Welcome. Good morning. We have very talented faculty joining us today for this side event. In the margins of 59th session of Commission on Population and Development, please keep your microphones muted so that you do not disturb the speakers and the audience. If you have any questions for the speakers, please either write in the chat box for the speakers directly or contact them directly at the end of the session. Their details are in speakers list. So let's get started with today's program. All right. And okay. Well, I think I'm getting good at it. Title of today's side event is Knowledge Generation and Dissemination, Achieving Quality Education and Universal Health Care. Women's Health and Education Center, its acronym is WHEC, is e-learning, e-health, and e-government initiative is an investment in health, education, knowledge, and technology, and ultimately, it is an investment in people and their future. Sexual and reproductive health is critical to overall health and well-being across the life course, therefore, has to be embedded and integrated with universal health care and universal access to all. Science and knowledge translation in reproductive health research and dissemination, exchange, and clinical application of scientific knowledge with the healthcare professionals worldwide and communities is the purpose of WHEC's Link Access Project. Today's agenda is fostering societies where everyone is included. Social justice and digital transformation improve access to essential services, creating opportunities for everyone, expanding UNESCO Chair Program, providing technical assistance and strategic advice to governments and their development partners, priority countries, fostering inclusive digital transformation. WHEC's e-learning, e-health, and e-government platform was launched on 24th October 2002 with collaboration of United Nations Department of Public Information, UNDPI, to disseminate reproductive health and research. It is serving with pride in 227 countries and territories, about 14 million visitors per year. WHEC wishes to express special thanks to these countries and territories for welcoming our educational web learning project. Their continuing support is deeply appreciated, and on 4th of July 2013, WHEC Global Health Line was launched for NGOs and academic institutions for the development and developing collaboration with reproductive health research, HRH division of WHO. In 2018, Link Access Project to disseminate reproductive health research was presented at UN headquarters in the margins of high-level political forum. LINK is an acronym, and it stands for Learning, Innovating, Networking for Knowledge. WHEC promotes and implements best practices in both developed and developing countries and provides educational programs free to the least developed countries. All human beings are born free and equal in dignity and rights. There are no strangers at Women's Health and Education Center, only the friends you have not met. Education for all and health for all is our vision. These are our efforts, and it's our promise. Strengthening trust in digitalization is a way forward. Launched in 2002, this portal is a collaborative effort of WHEC with UN, WHO, UNESCO, academic institutions, and many distinguished individuals. Of all the health statistics monitored by UN and WHO, maternal mortality and morbidity and permanent disabilities because of pregnancy and childbirth have the largest indiscrepancies between developed and developing countries. Building the capacity to care is at the core of our initiative. This portal provides comprehensive overviews of topics such as violence against women, obstetrics gynecology, prevention of obstetrical fistula, and better healthcare policies. The translations, we believe, will increase understanding of medical literature and help foster networks of healthcare providers around the world. AI literacy, it's essential, and we are doing the whole side event on it on May 6th. Some of this faculty will be joining us, and you will enjoy that side event on AI literacy. It's on May 6th. Artificial intelligence literacy, access to AI, global cooperation, and solidarity, including through multilateralism, is needed to facilitate fair access to AI technologies and address the challenges that they bring to diversity and interconnectivity of cultures and ethical systems, and to mitigate potential misuse. AI ethical issues surrounding AI literacy necessitate the cooperation of multiple stakeholders across various levels and sectors of international, regional, and national communities. WHEC aims to enable stakeholders to take shared responsibility based on a global and intellectual intercultural dialogues. Our efforts to advance global health for the last 25 years, this is the road we traveled. Established in 2001, WHEC undertakes projects and programs in collaboration with the UN, WHO, and UNESCO. In 2008, we established collaboration with the World Health Organization, WHO, and we were granted special consultative status with ECOSOC of the UN in 2008. Collaboration with UNESCO was established in 2021, and partnership with the Higher Education Sustainability Initiative, HESI, was started, and it was started with SDG Action Group in 2022. Future of education and health sectors is digital, providing a universal framework of values, principles, and action to guide member states in the formulation of their legislation, policies, and other human rights regulation must be protected. Now, summary and takeaway messages. Preparing the next generation of healthcare professionals in the international arena. and deepening their knowledge and improving the skill sets for a career in global health and global governance is urgently needed. Imagine students in developing countries and the United States simultaneously reviewing the same medical curriculum and learning from each other. That is at its best in an internet classroom, and it is the goal of this maternal child health essential knowledge portal, womenshealthsection.com. We have the knowledge, means, and motivation to act. So let us not wait a moment longer. Thank you very much, and this is my contact information. Please feel free to contact me anytime. And click to exit. All right. It is indeed my pleasure to hand over the platform to Dr. Colleen Kraft from University of Southern California Children's Hospital, Los Angeles. She was also 2018 President of American Academy of Pediatrics. Her presentation is on Toward a Health and Educated World, focus on educating girls and women. Go ahead, Colleen.
Okay, well, good morning. We're going to focus this next session on looking at women and education and reproductive justice. It is in some ways sad that this has to really be discussed over and over again because the evidence is so strong that if you expose women to education and you give them the rights of reproductive justice, that we have healthier children, we have healthier societies and healthier countries. But let's go on from here. So when we look at some of our learning objectives, let's review that strong evidence that economies function because of universal education and reproductive justice for women. We want to recognize all of the benefits for a society that is promoting education and reproductive services for women. And then identify important policy goals towards achieving that universal education and achieving reproductive justice for women. So why does women's education matter? Well, women are at least half, if not more, of the population in most countries. And women's education, first of all, expands that economic participation in skilled labor. But over the course of a lifetime, increases earnings and the national GDP. It improves health literacy and decision making and really extends even to maternal, child, and population health because if women are educated, they are empowered to provide the best health information to their children, to their families, to other members of society. And that women's education strengthens that community resilience and democratic participation. The global economic impact of educating girls. Each year of schooling, each year increases that woman's wages by 10 to 20%. Really important and really significant payback in educating girls. And educated women reinvest up to 90% of their income into their families and into their communities. So you have more income and then more income being invested locally where you can actually grow a community. And that higher female educational levels correlate with stronger national economic growth. We know from many different studies in many different places of the world that women's education lowers maternal and infant mortality. In fact, when so many factors were studied, including sanitation, medications, vaccines, access to medical care, the one thing that stood out in terms of the most effective way to improve maternal child health was women's education. Because when women are educated, they are more likely to vaccinate their children and take them to preventive health care. It reduces rates of malnutrition and childhood illness. And increases the ability to navigate systems and advocate for care. And in fact, in many communities, one of the jobs that educated women do is they work as health navigators to help to bring people to the health system. And that we know that if women are educated, that the age of marriage is older and there's reduced adolescent pregnancy, which again improves the outcomes for the children. There are intergenerational benefits for women who are educated. Those children are much more likely to survive till age 5. There is higher school attendance with those children and higher levels of literacy in the next generation. It has been measured that there's improved social development and also emotional and cognitive development. And educating women is key to breaking cycles of poverty and poor health. This is just a chart looking at different countries, the percent of girls in elementary school, and then the percent of girls in secondary school, and then the GDP per capita. So I'm going to start with Uzbekistan. 99% of girls are in elementary school, and that proportion stays high in secondary school. And the GDP per capita is about $3,600 per year. Bangladesh has lots of girls in elementary school, but there's a drop in the percentage of girls in secondary school, and you see a lower GDP per capita. Ghana, again, is a country with a high percentage of girls in elementary school, but far fewer in secondary school. And you can see the proportionality here. When you get down to Chad, only 60% of girls are in elementary school. And the percentage of girls in secondary school drops to 12.3%. And the GDP per capita is only $750 a year. So you can see that there's a really, really tight correlation between education of girls in elementary school and secondary school and the local GDP per capita. Well, what is reproductive justice? I've mentioned that before. This is a framework that ensures that women have a right to have children, but also that they have the right to not have children, that they have the right to parent children in a safe and sustainable community. And it really focuses on bodily autonomy and freedom from coercion. Very important in terms of having a healthy pregnancy and healthy children and healthy women. Reproductive justice is essential. It enables women to make decisions about the timing and the spacing of pregnancies. We know from our data that women who are pregnant more than 24 months in between pregnancies have much healthier outcomes for themselves as well as their children. And reproductive justice, the access to birth control and other reproductive rights really helps with that spacing. It reduces maternal mortality and unsafe abortions. It supports economic stability and workforce participation. It is protective for human rights and gender equality and ensures that there's access to contraception, prenatal care, and safe childbirth. There are economic benefits of reproductive justice as well. Women who have reproductive autonomy are much more likely to complete their education because they can time their pregnancies and have that at times when they are not in the middle of education or seeking a job. Because they have that autonomy, they can increase their workforce participation and productivity. And then there's reduced public health spending on preventable health complications. Reproductive justice helps a woman strengthen their family's financial stability as well too, which then just goes on to build the family and community. There are benefits to the health system, the local health system and the national health system to reproductive justice. There are lower rates of unintended pregnancies because women have access to birth control. They have earlier prenatal care, which has been shown to result in a healthier pregnancy. There's reduced strain on emergency and acute care systems. And then for the women themselves and the children, mental health is improved, trauma is reduced. If you look at global comparisons of reproductive health and socioeconomic indicators, and I had this listed by country, reproductive laws, maternal mortality, percentage of women in the workforce, the GDP per capita, and then the child health outcomes. Even the difference between two high GDP per capita countries, Norway and the United States, is remarkable. In Norway, they have progressive laws, so maternal mortality is very low. Women in the workforce is high, and the GDP per capita is very high. Excuse me. When you look at policy levers that work, we know that universal access to education for girls, comprehensive reproductive health care, paid family leave and childcare support, protection from gender-based violence, and economic and legal rights are really all parts of what promotes women's education and reproductive justice. So educating women is one of the highest return global investments. Reproductive justice is foundational to health, autonomy, and economic growth. And the policies that support women strengthen entire societies. So it's not just a moral imperative, it's a strategic one. So what's our call to action? We are looking for countries to invest in girls' education, protect those reproductive rights and access, fund community-based women's health programs, and then center women's voices in policy decisions because they really will make some of the best decisions out there. And with that, I'll say thank you.
Well, I hope you feel better, Colleen. Thanks for joining,
I'm
even though you
good.
were
Thank
sick.
you.
Excellent, excellent presentation. Next from India, joining us is Dr. Manisha Jawar. She's an obstetrician and gynecologist, and she's discussing near-miss obstetrics, learning from survivors, a precious introspection on our initiative in parental and antenatal care and insight to fill the gaps. Go ahead, Manisha. Oh, yes.
I'm audible?
Yes.
Yeah. Well, actually, I was so proud to see these data, and not just me. I think people from health department, even the UN agencies like WHO, UNFPO, the UNICEF, the ASHA workers, everyone would have felt very proud that more and more women in India are surviving. Mothers, rather, they are surviving. And 8 states of India have now reported MMR of less than 70 per lakh live births, which is actually the SDG goal for 2030. And state of Kerala has outperformed developed country like USA. It looked like we are moving fast and in the right direction. But to save more and more mothers, I thought of exploring the near miss obstetric events so that I identify the gaps and correct them so that more and more women could survive, still more could survive, and we reach the SDG goal of 2030. But actually, I was shocked to see nearly 40% of women who survived the near death event could not lead a normal life for years after the event, and 10% women had a disabling sequelae, and life had become a curse for these women. So, let me share a story of Mrs. Phi Lambda. She was a 19 years old primary gravida and referred from a village at 36 weeks with severe headache and seizures. Emergency C section was performed, but the baby couldn't be saved. Obstetric hysterectomy was performed because she went in DIC and was pouring like anything. Thanks to the massive transfusion protocol, availability of blood, factors, the lady was saved and was discharged after 28 days from the hospital. Now, this is not just one story. We have 2,000, approximately 2,000 such women who battle for survival in India just because they chose to be mothers and they chose to give life. But in past 20, because in past 20 years, MMR of India has gone down by 75 to 80%. So now we see approximately 300 to 500% rise in the survivors of near death event. So let us see how is our Mrs. Phi Lambda. She had not even come out of the emotional trauma of losing the child and the loss of capacity to bear a child at just 19 years of age. But she was facing domestic violence. Family and husband were torturing her for loss of child while we all were celebrating her survival. The hospital was celebrating, city was celebrating, state was celebrating, country was celebrating, and the entire UN was celebrating. She was living a bad life. She had a weakness which had made her dependent and was not able to come out of it, and was a burden for family because she was unable to perform even the household chores. To add fuel to the fire, she tested positive for hepatitis B also. Probably she contracted because of heavy blood transfusion. Is statistical success so good, or it is a lifelong struggle? To sum up, nearly 10% of maternal MNM survivors suffer like this, just like Mrs. Phi Lambda. And each moment they think, why did I not die? They suffer long-term health problems. 30% suffer long-term health problems like anemia, chronic fatigue, renal or cardiac dysfunctions, the mental health issues. Approximately 60% of women are lucky to have a near normal life. To sum up, of approximately 50,000 deliveries in India per day, 2,100 life-threatening events occur every day. And 70% of the women who go in this life-threatening event or are termed as maternal near miss or maternal mortality are unbooked, meaning thereby they didn't take any antenatal care, no iron, no folic acid, they just landed in emergency. And few of those who were considered booked had booked late in third trimester, meaning thereby their first antenatal visit happened late in first trimester. And most of these unbooked cases didn't take antenatal care because of lack of awareness or social or familial constraints, cultural beliefs, which discouraged antenatal visits, at times economic challenges. But it's moment to say that very few didn't attend antenatal because of lack of healthcare infrastructure or unavailability of doctor, at least in Gujarat. When antenatal care is not taken, risk factors go unidentified, like iron folic acid supplementation is missed. Chances of landing in complication therefore increase because we don't check for blood pressure, we don't check for diabetes, sugar. So this is the first of the three delays, the delay in seeking help, contributing to the 2,100 life-threatening events per day. Now, out of these 2,100, the unfortunate mothers, these 2,100 unfortunate mothers, those who could reach the high-tech ICUs without second delay survived, and approximately 70 to 80% of 70 to 80 of them who made the second delay also in reaching the facility or faced the third delay because they didn't receive care in time, they succumbed. So these are the approximately 75 maternal deaths per day. This is approximation, and approximation is based on WHO criteria because I couldn't get the state-wise criteria of India. So the Ministry of Health and Family Welfare had laid down a maternal near miss policy in 2014. WHO too has such a policy. WHO has a policy whereas the Indian ministry focuses on audit and system improvement, WHO focuses on quality of care. And the criteria of Ministry of India is as per the Indian setup, whereas WHO has standard global criteria. The follow-up visits are not fixed, neither in WHO nor in Ministry of India. But most of the time, the visits are limited to those who have had suffered some long-term illness, whether it is a kidney problem or it is a cardiac problem, or like our Mrs. Phi Lambda developing hepatitis B and all. So the follow-up visits are very limited and no policy is clear for the follow-ups of the women whom we have saved. This gap can be transformed into an opportunity, I think, because this gap, because these survivors can become lifesavers. I think when these survivors can take the role of a brand ambassador of antenatal care in their village and the villages in the vicinity, since she understands the local beliefs, she understands taboos, social barriers, she can communicate in the actually in the culturally acceptable barrier language and way to, and the way her fellow people would have already, actually the fellow people are already discussing. In India, the villages are like a family. The fellow people, if something goes wrong with somebody in the village, everyone is discussing the event. So fellow people already know about the event and they are worried how we should not land in such an event. So this is the right time. We advocate antenatal care to these people, we advocate institutional deliveries to these people, we break the myths around the antenatal care, we encourage early pregnancy registration, we promote institutional deliveries, and above all, we create awareness about the government schemes, the government of India schemes like Janni Suraksha Yojana and Pradhan Mantri Matru Vandan Yojana, whereby we also give, the government also gives money to the pregnant ladies. And this is a double bonanza because the women, the 30% of the lucky women who nearly survive normally the near death event, they have mental issues or some anxiety issues, weakness, because more of these mental issues can be solved because now if they are taking such a role, their self-esteem will rise. They won't suffer domestic violence. They won't suffer any problem in bringing up their children if the child survived. And this will meet our all the SDG, all the WHEC goals, whereby we should include everyone, we should reach to the most in problem people or even women. And this is nearly a double bonanza because it is good for economics also. If we think of not just the mother, she is coming out of her mental trauma, she is becoming independent. The one who was lying dependent on everybody was facing domestic violence because she was not earning. So the government saves at ICU cost. ICU cost is approximately 5,000 to several lakhs for saving one maternal near miss. If by promoting antenatal care, and everyone knows antenatal care promotion will definitely save mothers. So out of these 2,000, approximately 2,000 maternal near misses every day in India, we can at least minimally save 600 to 800. If we are able to prevent such 600 to 800 maternal near miss every day, and this data is extrapolated by NFHS 5 study, this would save 35 to 100 million per day, which is a whopping amount. Mental health issues of survival will definitely resolve. So purpose in life, because purpose in life restores identity and is a rehabilitation in itself. So I feel without making a fourth delay, WHEC should proceed for a pilot model, identify eligible maternal near miss survivors, provide a short structured training to these women, assign them as a village health coach, track for over 6 to 12 months, and outcomes can be measured as the percentage increase in early ANC registration, percentage increase in more than women taking more than 4 or more ANC visits, the increase in the institutional delivery rate, and reduction in delays and complications. So let's avoid the fourth delay, which may be from our side. Act today and turn every near miss into a multiplier opportunity. Thank you.
Well, thank you. It was a real eye opener, and I accept your challenge. I am glad you put the third dimension to the statistics. Only thing we think you're dead or you're alive. we never think you are alive this
Suffering.
horrible experience, and how will your life be? It's not a book picture. I might get a chance again to have a side event for World Health Assembly, which is usually end of the May again. Last year we did that. Uh, Help me write this proposal you are saying, and if I get it end of the May side event, we'll organize it. Colleen, you must come.
I'd be
Okay.
happy to.
Yes.
Yeah.
Yeah, last year we did 78th World Health Assembly. We got it through the UN Foundation. So,
Oh, that's
hey, I
great.
get
Yeah, let me
lucky
know the
sometimes.
dates and I'll see if I can make it.
Yeah, yeah. Otherwise, internet is available. I know you travel a lot. Okay, now from my hometown, and the guy I like it very much. I like his wife very much, but David is a nice guy. He's from Western New England University. It's not far from my house. And his AI is his area of specialization. His topic is, could agenetic AI help close the gap between knowledge access and real world action for women's health and education? Go ahead, David.
Yeah. Thank you, Rita. Thank you, Women's Health and Education Center. And thank you, co-presenters. This has been an informative and important session. So, as Rita had mentioned, we're asking the question, could agentic AI help close the gap between knowledge access and real-world action? So, one of the things I'm curious, even though this is a presentation, I would be curious to know how many of you have worked with or heard about agentic AI. You don't have to answer. But what I'm finding in my research and in working with faculty at Western New England is that not a lot of folks are aware of what agentic AI is. So we'll give you a little bit of an introduction today. So if we think of standard AI like chatbots, like ChatGPT, and those kinds of things, a lot of people think of them as like supercharged, um, Google being able to find information, and it does do that, but it sometimes retrieves false information, or it sometimes provides hallucinogenic information. In other words, it makes stuff up. It doesn't uh, basically give you solid, good, vetted information. So, agentic AI can take this to further steps. So basically, what agentic AI does is it in essence sort of acts like a human, and it can do a job. It can go from a starting point to a finishing point, and um, a lot of the main businesses in this country are now investing in agentic artificial intelligence. So back to the original question, could agentic AI help close the gap between knowledge access and real world action? Um, Knowledge access is knowing a service, program, or resource exists, like finding a clinic or finding a scholarship or a learning pathway, getting clear answers or directions. So the gap between that and real world action is where agentic AI may be able to help. So um, when we talk about real world action, things like actually booking an appointment or completing an application or navigating paperwork and follow up, actually changing the outcome. So the core question, can AI agents help women move from knowing to doing? So why does the gap fall harder on women? Well, we've just had some pretty decent presentations already in this session. So I won't spend a lot of time here, but the gap does fall harder on women, time poverty aspects, geographical isolation, financial, institutional distrust, language literacy, and social gatekeeping. Very serious issues. So if we look at how does agentic AI fit into the broader AI landscape, if we look at this first box here, AI, this is what a lot of us who are using AI and adapting AI are used to, the chatbots, where they can find patterns and predictions. So I just misspoke. The AI, the first box is really more about machine learning, finding patterns and predictions. The Gen AI is what we're more familiar with here. And this is the chatbots, and it generates text, code, or images. And there's this, it's fairly new, but it's been around a while. RAG, and that stands for a retrieval augmented generation. And this improves what the system knows. So if we think of RAG, it retrieves trusted sources before answering questions. So it's basically injecting into the Gen AI prompts information that is relevant to providing an answer. And if you think of RAG in simple terms, if you were taking a test from memory, that would be more of an analogy to Gen AI, where with RAG, taking a test with the open notes would be a little easier. So that it's the same with with Gen AI and using retrieval augmented generation. So what professors, just to give you an idea, might do with RAG is include, chapters of a book, and then maybe ask the Gen AI to create a quiz from those chapters. So the RAG really makes the outputs more trustworthy, rather than just relying on the training data of the large language model. So fourth thing here is the agentic AI. So the agentic AI can plan, it can decide, it can take multi-step actions with tools. So agentic AI is some folks in business are thinking of using AI agents almost as employees, where the agents actually go and do work. And in this case, we talked about, actually make an appointment rather than just find the source of where an appointment could be made. So where does the gap actually live? There's three layers of friction, and the first is largely solved by standard, chatbots, ChatGPT or Anthropic Claude or Perplexity, etc. And this is awareness. So in awareness, search engines, apps, social media have made awareness far more accessible. So knowing something exists we're calling this the easiest layer, but it's obviously not always easy. And chatbots and standard AI have mostly addressed this. Where agentic AI can help is in navigation, looking for eligibility rules or forms or referrals, language barriers. Every step could be a drop-off point, and women navigating caregiving or distrust often exit before reaching action, basically giving up. So even if they get through awareness, navigation can be a large layer of friction. And then finally, taking this step to where the outcomes live, booking appointments, setting up reminders, deadlines, paperwork, follow-up. As we know, no action taken means no change achieved. So this is the hardest layer and the most consequential. So most digital tools will address the awareness. The more consequential issues live in navigation and execution. So how does retrieval augmented generation give an agent trustworthy current knowledge? So if a woman asks, is there a free cervical screening near me this week? The RAG searches a curated knowledge base of local clinics, eligibility rules and schedules in real time. And the augment part of RAG is these retrieve facts combined with the query. So the AI agent reasons from verified current data, not stale training data. And then acting, the agent books, confirms and sends a reminder citing its sources so the outcome is traceable. So RAG is what separates a confident sounding guess from a trustworthy, citable answer. In health and education contexts, that distinction is not just cosmetic, it's clinical. So when you think of an AI agent, the next thing that comes to mind is the pipeline. What is the agent actually doing? What are the steps? And what's so cool about AI agents is we can actually create an agent that connects AI agents. So again, it's very powerful because it uses artificial intelligence to reason, and even it could make decisions if you allow it to make decisions, or you can confirm steps before going to the next step. So agentic AI pipeline is a very powerful tool, and businesses are investing billions and billions of dollars into this technology as we are sitting here. So what could an AI agentic pipeline do? Well, it can ask, it can retrieve, it can interpret, it can recommend, and it can act, and it can escalate. So if a issue is not resolved, it can escalate that issue to appropriate resources. A health example: find maternal health resource, check local eligibility, suggest nearest clinic, draft visit questions, send appointment reminders. So agent could do all of those things. Could for education, it could find relevant scholarships, explain requirements plainly, and help gather materials, draft or review the application, and track deadlines and follow up. And just to give you an example, this semester at Western New England University, in a few of my classes, we created a job search agent for students that was really, really cool. And what the students did is they filled out certain data inputs, like what is their name, what kind of a job are they looking for? Are they looking for beginner or intern level, entry level, intermediate level, etc. What were their skill sets? What were their soft skills? Did they want hybrid work? Did they want remote work, or did they want on-site work? what was the geographical location that they were interested in. And what this agent would do is it would go out onto and then they would post their resume as well into the inputs, and it would go out and it would look for jobs, and you could set the number of jobs that it would find, and we had it set for 10, and then it would pick the 5 best matches, and it would explain why those matches worked the best. It reviewed their resume and it looked for gaps. It reviewed the resume and suggested improvements in the resume. It wrote like a sample cover letter, and based on the 5 best matches, it would ask 3 interview questions to help prep, and then it gave like a 7-day plan. And the cool thing about this agent is you could run it in the morning, change it, and run it at night, and you could run it every day. So, and the students figured out really quickly that they could modify these agents and add things like, hey, I want to know what the salary range is for these jobs. And then other students said, rather than just getting the company name and the job description, I want more. I want a full description of the job. And another student, said, hey, I would like to have a link so that I could actually apply for the job. And those additions within the AI agents, and I mean, we're just having like junior, senior students at, making modifications to these agents as we're moving through the course. So agents are real, and they're here now. So it's something I wanted to make everyone aware of. So who might benefit and who could be left behind? 2.6 billion folks without any internet access. That would pretty much exclude them from agents. There's 189 million more men than women online globally, and approximately 122 million girls are out of school globally. So there is a definite equity risk here. Agentic AI requires a device, internet access, and digital literacy, and none of which are equally distributed. So there are quite a few points here. So there's risk of widening the gap rather than closing it. And women with the fewest structural barriers would benefit first, and those with the greatest need may benefit last. So what would it actually take to make these agents work? Connectivity, community-led design, multilingual competency, data privacy, huge. Accountability mechanisms. When agents make errors in health or educational context, someone must be responsible for correcting them. Humans in the loop. So basically, these two go hand in hand. Keeping humans in the loop is an important part, and you can absolutely do that with these agents. You don't have to set them to auto do everything. So can agentic AI, close the gap between, awareness and action? Yes, but only if we choose to build it that way. Agentic AI is the first technology with genuine potential to address not just information access, but navigation and execution layers where the gap truly lives. And retrieval augmented generation equips agents with reliable, verifiable knowledge. So the difference between a system that sounds fluent and one woman can trust with her health decisions. So RAG makes that difference. The question is not whether the technology is capable, it's whether we choose to direct it where the need is greatest and design it with the communities it aims to serve. So it's not only a technology question, it's a design, access, trust, and equity question. So thank you. That's my comments.
Well, thank you, David. It's always eye-opener for me. And I'm a technology idiot anyway, but I enjoy listening to your AI. And I'm glad you are joining us on May 6th. And he will talk more about AI. Okay, the next speakers, we have two of them, Donna Jenny, who is my neighbor, and another is Emily from Westfield State University. They are presenting Westfield State University's impact on regional access through its healthcare and poverty simulation. Go ahead, Donna and Emily, go ahead.
Good morning. My name is Dr. Donna Jenny. I have the privilege of also serving on the Westfield State University Alumni Association Executive Council. And through this work have connected these two organizations, WHEC and Westfield State, to highlight the amazing work of the university in the Northeast region. Westfield State has been an innovative education collaborator since its founding in 1839 by Horace Mann, and was the very first coeducational college in America to offer an education without barrier to race, creed, or economic status. Today, it remains a vital component to the fabric of Western Massachusetts and beyond, and has grown to include programs in health sciences, nursing, physician assistant studies, and more. Emily Ciccolo, Master of Public Administration, class of 2026, serves as the university's healthcare career navigator and will share with us an exciting, innovative initiative that recently introduced local high school students to careers in healthcare and the programs Westfield offers that increase the region's access to quality and education healthcare while seeking to reduce the burdens of economic barriers. Welcome, Emily.
Thank you so much for that introduction, Donna, and also Rita, thank you so much for having me. So as mentioned, my name is Emily Ciccolo, and I am the Healthcare Career Navigator here at Westfield State University. And as mentioned, today I'll be talking to you guys about some really cool events that we have had recently. So first, I wanted to give a quick overview of what healthcare career navigation entails. I was hired 3 years ago under the Better Together grant through Bay State Hospital in a collaborative position between Westfield State University and Springfield Technical Community College. Healthcare career navigation is all about helping high school and middle school students learn information about healthcare careers early on so that they have the tools to be successful throughout college and to begin their careers. A lot of my work includes removing barriers, such as students not understanding words like baccalaureate, early intervention, teaching students what the requirements are for programs like nursing as early as their freshman year in high school so they can prepare for throughout their years in high school. Career exploration, explaining that there are multiple different careers and different places you can work in healthcare. I found that often students thought you could only work in a hospital as a healthcare professional, as well as creating a system of support for students. So they're introduced to someone they can feel comfortable with asking questions and reaching out to, instead of just finding a random name on a website and emailing them. So recently, the newest event that was created in order to show high school students the diverse options in healthcare careers in a way that felt accessible, relevant, and engaging was a longitudinal simulation. This longitudinal simulation had an audience of 140 local high school students, which required an approach that held their attention while also delivering meaningful information, which is why we used the narrative-based longitudinal simulation. Rather than overwhelming students with facts about different professions, the simulation demonstrated how each role naturally fits into a patient's recovery journey. Another key objective of the simulation was to broaden students' perceptions of healthcare beyond traditional, visible roles such as doctors and nurses. The simulation highlighted professions like athletic training, physical therapy, social work, and physician's assistants, as well as many others. The simulation emphasized that healthcare teams are multidisciplinary and interdependent, and the experience aimed to help students imagine themselves in these roles by connecting careers to real action and patient outcomes. The simulation functioned as a showcase to what Westfield State offers, in particular, hands-on career-focused healthcare programs. The simulation demonstrated how education at Westfield State can translate directly into the impact of real-world work. The goal of the simulation was not only to inform, but to inspire the 140 high school students to consider healthcare pathways they may not previously have imagined. The simulation began with Coach Lou sustaining an injury while playing pickleball, which is a fast-growing and relatable sport for many audiences. This initial moment was critical because it demonstrated how injuries often occur during everyday recreational activities and not just elite athletics. Students observed immediate response to this injury, including recognition of symptoms, basic first aid, and decisions about seeking further care. This stage introduced careers involving acute and on-site care, such as athletic trainers and emergency medical professionals. The simulation highlighted how these professionals assess risk, stabilize the patient, determine next steps, and emphasize the importance of quick thinking and strong foundational knowledge. The realism of the scenario helps students appreciate that healthcare professionals must be prepared for unpredicted situations and work calmly under pressure. Following the initial injury, the simulation transitioned into medical evaluation and the diagnostic phase, showing students what happened after a patient seeks formal medical care. This included things like MRI and EKGs. These were narrated in the simulation and not shown. This portion also highlighted a team huddle where all of the healthcare professionals worked together to get Coach Lou back on the pickleball court, explaining their reasoning and what they wanted the healing process to look like for him. This was another great way to show the high school students how healthcare professionals have to work together in a team in order to keep the patient healthy and safe. The final stage of the simulation focused on rehabilitation, showing how recovery extends far beyond the initial treatment and also does not always happen in the hospital setting. The high school students observed the coach through physical therapy and exercise-based rehab, observing how structured movement, strength training, and mobility work together to support healing. This stage highlighted careers such as physical therapy and exercise science professionals. The simulation demonstrated how rehabilitation plans are individualized based on injury severity, patient goals, and progress over time. Students saw how professionals monitored improvement, adjusted exercises, and motivated patients through setbacks by seeing tangible progress over time. The high school students could clearly connect professional intervention to improved quality of life. At the end of the simulation, our pickleball coach, Coach Lou, was right back to coaching and fully healed. After the high school students were able to watch the simulation, they were also able to tour the entire campus as well as speak to each of the professionals that were present at the simulation. This gave them a chance to ask more detailed questions as well as get clarifying information about what they saw in the simulation. This event was also important for our current students who participated because they were able to work together in a way that they might not get to in their everyday classes. Being able to practice working interprofessionally is a very important aspect and something that Westfield State puts an emphasis on, so it was very rewarding to see the students working together in a way that they might not have had the chance to before the simulation. While the simulation was technically scripted, each of the participants made it their own and used the knowledge of their actual discipline or future career in order to make informed decisions about how to take care of our patient, Coach Lou. It was great to see the high school students so engaged in the simulation, but it was also inspiring to see how each of our current students work together, especially on stage where they might not have been comfortable beforehand. This simulation also included graphic design, who made us this easy to read flyer to hand out to the students that attended. And this gave a snapshot of every participating discipline, including theater arts, who helped a lot in the actual conception of making the simulation happen. And each of these links is actually something that the students can click on right from a PDF. So it made it accessible to each of them as well. Another event that I wanted to touch on very quickly was the Community Action Poverty Simulation, which we hold every spring for our current Westfield State students. Normally, students in the PA programs, nursing, social work, and psychology programs attend, but every student is welcome. This poverty simulation is meant to promote poverty awareness. Each student is given a family and they have to live a month, which is actually 15-minute segments in poverty. They have to learn how to feed their families, get to work, and pay their bills. The simulation is meant to bring an understanding to those who may be living in poverty. Every year, the event sheds light on things that people might have not understood before. And one comment that was made this year that I think is very important is a student mentioned that in the simulation, they were given high blood pressure, but they were not able to go to the doctor because they simply did not have the time, because they were too busy paying bills or trying to get around town and taking care of their students or children. She mentioned that it's important that we don't judge patients if they let a medical issue go too far and don't come to see them, because we never know what might be going on at home. And we don't know if maybe it is simply not a top priority for them because they are too worried or busy dealing with other things. I thought it was a great way to tie back into her profession as a PA and really give a different perspective on the patients we may be seeing every day. That is all, and thank you so much for this opportunity to be here. I really appreciate it.
Oh, thank you, Emily. It was very eye-opener. I remember I am almost 75. When I was growing up, there were only two professions. If you are a woman or girl, medical profession, become an OBGYN or pediatrician. That's the option. That's all you have. And if you are a guy, engineering suits you better. But because somehow the guys know mathematics, I don't know why. And my mother was a professor of mathematics. So it's eye-opener. There are a lot of professions now open to girl and women. All they have to do is go out and study. Don't get pregnant at the age of 14, for God's sake. Anyway, I'm retired now. Now the next is from our northern neighbors from Canada, Dr. Bharat Maheshwari. This is a joint initiative between University of Windsor, Canada, and Indian Institute of Technology, Jodhpur. This project brings together Indian and international educational institutions and create a unique lab for studying multidisciplinary challenges by the massive temporary city which crops up to accommodate people visiting this big festival. It's really a massive festival in India. I think it happens every 2 years or something like that. Go ahead, Mahesh.
Thank you,
Bharat,
Dr.
go ahead,
Rita.
Bharat.
Let me give a little bit of background. I come from a business school. My PhD is in management and large systems. And I think what I'm going to speak about is going to bring together some of what other speakers have mentioned before in this session. And thank you for inviting me to this amazing session. Currently on sabbatical, I am teaching in India in IIT Jodhpur, where I'm a scholar in residence. But also I am advising the faculty development and again teaching the MBA program partly at institute in Nasik called KK. Now, while we were sitting together discussing what is the future of education lies with the heads of all the departments, comes the challenge, hey, students are getting bored in the classroom. And as David said, agentic AI, RAG models, all are coming in place and things are being done for you. So AI as an employee is a very near possibility. In fact, I have developed several AI models who do work for me. In fact, this presentation you see is generated by AI. I gave the material, but AI did the beautification and coloring and everything else. So the new reality today is a world of AI. But AI, as you know, runs on data. Medicine also runs on data. The stories, whatever we can develop in the lab, has to connect with the real-time data. What AI can do is what AI can learn. And where is the learning happening? Where are the people? Because in business, what we do is bring together problems and solutions. And eventually it is about people. And so much so, this is again a CPD event, Commission of People in Development. So I thought, let's bring it all together. So to base my talk, I have to introduce a couple of things, Live Lab and the Kumbh Mela, and how does it connect to the women's health and what are the opportunities and what can we do together and how can I invite you to join this live lab. We saw presentations from many faculties here. So what can we do together? So Kumbh Mela is, let's talk about the live lab first. And I'm a big proponent of live lab because I've seen attendance go low in classrooms. Even graduate students don't want to attend classes. We are in a world where we want to record, we are on Zoom, we are multitasking, our attention span is low. But reality lies in our world of business, in coming close to the customer and providing solutions which stick in. Because we may celebrate, as Dr. Jawar has said, survival of patient, but we may not know what the patient goes through. Everyone else is celebrating, but the patient is going through hell. So Live Lab is a user-centered open innovation ecosystem that seamlessly integrates real-life environments, fostering collaboration among various stakeholders, including researchers, industry, users, public sector. And we were talking about Live Lab, we were talking about student engagement, we were talking about research and solving, and we were in the city of Nasik where I was visiting and taking a facilitation session of all the principals and deans in this Kekewag Institute. So it came in, what is happening in Nasik, which is unique, where we can bring it all together. And I would like to say Kumbh Mela happens in Nasik every 12 years, and it is to happen in 2027. And this is such an event. For centuries, it has happened in India. It happens in four cities in India. Allahabad, it happened last year in 2025, and it was expected about 400 million people visited that place. Different sets of people from around the world came together to discuss, and that is the idea. It came together as a religious practice, came together. People, when they come together, they entertain. People, when they come together, they eat. People, when they come together, they enjoy. But so much humanity coming together poses some challenges, poses some opportunities, poses some avenues that we can educate them, poses avenues that we can test products. Biomedical engineers can test devices. Doctors, public health people can get masses. They can talk to them about challenges and what they can do. So Kumbh Mela in Nasik is the next big event in the Kumbh series, and it is happening in 2027. I have an institute in Nasik, which is the host institute, but there are also other institutes which said, hey, we can participate in it. We can do multidisciplinary research. We can talk about civil engineering and sanitation. Now, health professionals, how can they use it? So what is the opportunity here for women's health? Now, just imagine 120 million people, and half of them are women. Just imagine they're gathered together. Just imagine the challenges they face in such a small space they are in there. Just imagine what we can do if we can create a camp, we can create testing of products, lifetime data collection, we can do applications. Now, it is the world of cell phones. It is the world of devices. I can regulate my sugar by the device and connecting it to my phone. I know what am I eating and how is it affecting. So opportunities arise when this happens. And I, as a researcher who is a global researcher, I interact with schools and colleges around the world. I became so excited. I'd say, okay, let's do the live lab and invite the world to participate. Come in from different divisions, departments, institutions. And again, right away, I saw institutional partnerships. I saw a large gathering. I saw challenges from my discipline, but from others. And I am cross-functional into healthcare because I co-founded Ontario Health Alliance here in Ontario, where we are solving problems like delay and denial of emergency care. We have a huge shortage of ERs are very full, wait times are like 14, 15 hours. Yesterday in my city, there was a blackout, no ambulance was available. So those are the things which we can solve by technology, getting people together. If we can keep the CTAS level 4s and 5s out of the hospital because they don't need to be in ER, they can be treated outside. So as a management scholar, I do deal with healthcare, but when we have a massive set of people, that is primary data. See, a lot of times where our education institutions are falling short is we are working in the lab, we are not getting out of the lab. Yes, labs are very, very important. But for our technologies, for our methods to work well, we need to go out and work with people. And this is where this is a huge research opportunity. If I were to summarize the research opportunity here, the Kumbh Mela presents and the Live Lab presents is on experimentation, interdisciplinary collaboration. We can bring together diverse expertise and perspective. And so well did Emily state before how she, using a simulation, gave us a view to the young people that what can they do in the world of healthcare. It is not just the doctors. It's a whole set of clinicians who make healthcare work. And again, it is more important to work on good health. Then what we do prominently today is preventing bad health or fixing bad health mainly. We can work on a way where we can, through education and methods which we can use, promote good health. And that will be the best. And Dr. Javar and Dr. Colleen, they also gave us so many indications why this is important. Engaging users, getting the valuable data and insights, passing on what is important. So research domains for women health, I can see an opportunity for women health researchers all around the world to connect with us at KKWAG. We can host you at the Kumbh Mela, and we can study together public health, gynecology issues, environment health, sociology. We can even test so many opportunities with biomedical engineering and come up with some comprehensive solutions which can make life better. What I did, I was associated already with 3 institutes. University of Windsor is my host institution, where I'm a faculty member in Odette School of Business. I'm also a scholar in residence in the IIT system at IIT Jodhpur, and KKWAG involved me for helping their faculty develop new programs. And here came the opportunity. And now I'm finding many other institutions are joining. and SVNIT Surat has joined, IIT RAM at Gandhinagar has joined, Carleton University here in Ottawa has joined. I would love to see if Westfield State University can partner with us. Yesterday, I was with the Vice Chancellor of Assumption University, and they're happy to come along. So this is what the Live Lab presents. Not just women's health, but definitely so much opportunity in women's health, because we can get together and collect some real-time data. We can do camps there. We can give education in a entertaining mode, awareness. We can gamification of education, and taking it to the masses has worked out so well. We have data to prove that if we can make it interesting, if we can make it convenient, if we can take it to the people, it works. And Kumbh Mela presents such an opportunity. So if we were to take a small case study of what we can do with women's health, real-time monitoring is possible. Now, how would we do real-time monitoring? We can look at some projects around women's menstrual and reproductive health. We can take projects around identifying risk among women during the high-density gatherings. Too many people. Sanitation is an issue. You can catch something. Then we can leverage technology. So as David has put in, RAG models are great. Agentic AIs is exciting. I just built a platform which uses multiple agentic AI agents, and these agents can talk to each other. These agents can act on our behalf, and such a great opportunity to provide and make some agents and test them. Are they working? Because people are the final frontier here. And having a massive gathering, that's an opportunity. We can do a lot of secondary objectives also. We can effectiveness of interventions. We can look at, are our vaccines working? What is the last mile challenge? Why are people not accepting them even if we see that they are working very well? Behavioral issues. We can do lots of study types, lots of participants. I think I was reading this article just this morning. It came to my news feed. Somebody has done studies with like 20,000 users. Now we're talking about 120 million people attending. And now if we have 60 million women and you want a data set and a size, such an opportunity. So Live Lab also opens not only the health researchers, we can give opportunities for statisticians, we can give opportunities for all disciplines. That's pretty much my spiel here, but if I want to conclude, and it seems my screen is
What happened? You froze, Bharat. Hello?
Yes, he
Bharat?
seems to have froze.
Yes, I think his computer froze because my side is working. Are you finished, Bharat? Hello? Well, I think he concluded. If I get him back, he can have his last couple of minutes. Otherwise, thank you very much, Bharat. It was quite an eye-opener.
Dr.
And
Rita,
I definitely want to chat with you again for
Dr. Rita,
this.
I think Dr. Bharat is coming back. Actually,
It's coming
there was
back? Good.
some
Good.
technical problem. Yeah.
Okay,
Just
here it is. Yeah, it was.
Yeah.
Yeah, I will give him the last 2 minutes, then stay for a little while. I want to chat with you. I think we froze technology. Yeah, it's good to believe in human beings. Yeah. Okay, you have last 2 minutes. Go ahead, Bharat.
Yeah, so sorry about the technological mess. My computer suddenly froze off. But again, to conclude, human part in technology is important, and opportunities like what we have in Kumbh Mela Live Lab are just amazing. We need to build these technological solutions and take them to the real world and test them out. And to my final words, that hey, join us at KKVAC. We'll be happy to host you, and we still have a window of about a year and 3 months. That is an excellent time to plan the projects, apply for grants, work together with colleagues, and there are multiple institutions working, and we can do such an amazing job of formulating technologies, identifying problems, and come up with solutions which work. Thank you so much. Thank you so much.
Thank you. Let me stop recording
Okay.
so we can talk freely. Pause, stop.